Picture this. A patient walks into the clinic, or maybe the ED. They've been feeling pretty lousy for the past couple of weeks. Fatigue, some muscle aches, maybe a little weight loss. You grab their vitals, and they're running a fever. Okay. Then you put your stethoscope to their chest, and you hear it, a completely new, distinct heart murmur. That combination right there, it should absolutely set off alarm bells in your head. Salam, welcome to A Little Push, 5 Minutes Medical Mnemonics. Today, we're focusing our explainer on a seriously high-yield, board-favorite topic that you are guaranteed to see on your exams and on the wards.
So, why exactly does a new heart murmur plus an unexplained fever equal a potential medical emergency? Well, those classic signs point straight to infective endocarditis. Basically, we're talking about a severe microbial infection right on the heart valves themselves. Bacteria, or sometimes fungi, manage to get into the bloodstream. This could be from a routine dental procedure, IV drug use, or maybe they just find a pre-existing valvular lesion to latch onto. Once they're in the blood, they set up camp right on the endocardial surface of the heart. To master the clinical presentation of this really complex disease, we're going to use one of the absolute best memory tools out there.
And here it is, the ultimate mnemonic framework from Jane. You see, persistent bacteremia and the showering of systemic emboli lead to a huge, diverse set of physical findings, and this mnemonic organizes the whole shebang perfectly. We're going to break this down letter by letter. Keep this framework locked in your mind's eye, because if you can remember from Jane, you're going to instantly recognize the peripheral signs of infective endocarditis.
All right, kicking things off with the F in from. F is for fever. What's absolutely crucial to note here is that this is the single most common presenting symptom of the entire disease. We're usually looking at a temp of 38 degrees Celsius or higher, which is 100.4 Fahrenheit. Because the infection is literally thriving right inside the bloodstream, sitting on that heart valve and just constantly shedding bacteria, the patient's immune system gets locked in this systemic overdrive, which gives us that persistent fever.
Moving right along to R. R stands for Roth Spots. If you grab your ophthalmoscope and take a look into the patient's eyes, you might spot these really distinct, round retinal hemorrhages that have these clear, pale, or kind of white centers. The key takeaway here is the pathophysiology. These aren't just random bleeds, you know? They're an immunologic phenomenon. Circulating immune complexes get deposited in the tiny vessels of the retina, causing localized vasculitis, and then boom, a hemorrhage.
Next up is O. O is for Osler Nodes. These are raised, red-purple, and crucially, incredibly painful lesions that usually pop up on the fleshy pads of the fingers and toes. Just like Roth Spots, they represent an immunologic response. Now I want you to burn this memory trick into your brain right now. Osler equals ouchie. Say it out loud if you need to. Osler equals ouchie, because these things hurt. This is a massive distinction that you'll absolutely need to recall later.
Wrapping up the first half of our mnemonic, M is for murmur. But listen, we're not talking about some benign flow murmur here. We are specifically looking for the development of a completely new heart murmur or a really noticeable change in one the patient already had. As the bacteria multiply, they form these nasty destructive masses made of platelets, fibrin, and microbes. We call those vegetations. These vegetations physically wreck the valve's ability to close properly, leading to regurgitant blood flow. And that's exactly what creates the murmur you hear when you listen in.
Okay, let's transition over to the JAN half of the mnemonic. J is for Janeway Lesions. Take a good look at what we've got here. See these small erythematous or red macules on the palms of the hands and the soles of the feet? Unlike Osler Nodes, these are completely painless. A brilliant way to remember the difference is that Janeway lesions are just there. Or you can think Janeway equals pain away. They don't hurt because, unlike Osler Nodes, they aren't driven by an immune reaction. Instead, they're caused by tiny septic microemboli that shoot off the infected heart valve and get stuck in the peripheral capillaries, causing little microabscesses.
A is for anemia. Specifically, we're talking about a normocytic anemia. Think of this as your classic anemia of chronic disease. The patient's body is battling a really prolonged, severe, and metabolically exhausting infection. So in response to that chronic inflammation, the body just naturally dials back red blood cell production. That's a big part of why these patients experience such profound fatigue and pallor on top of their fever.
N is for nail hemorrhage. Notice the striking visual we have up here. These are commonly known as splinter hemorrhages. You can clearly see these thin, red to brown linear streaks right under the nail bed. It literally looks like the patient jammed tiny wooden splinters under their fingernails. This is yet another vascular phenomenon. It happens when septic microemboli damage the superfragile capillaries right there in the nail bed. Finally, we hit E, which stands for emboli. Now, this is the real danger zone. Those vegetations sitting on the heart valves are highly friable. That means pieces of these infected, fragile clots can just break off at any given moment and travel freely right through the bloodstream. If the vegetation is on the left side of the heart, those systemic septic emboli can shoot straight up to the brain and cause a devastating embolic stroke, where they can travel down to the abdomen and cause a splenic or renal infarction.
Now, I want to pause the mnemonic progression for just a second to highlight a classic exam trap. Let's look at a side-by-side comparison that you absolutely must master. Test writers love, and I mean absolutely love, to try and trick you by swapping the definitions of Osler Nodes and Janeway Lesions. So how do we beat the trap? We just remember our rules. Osler Nodes are ouchy, they're painful, raised, and immunologic. Janeway lesions are just there. They're flat, painless, and vascular. Keep those two straight, and you are going to easily secure those points.
Another incredibly high-yield clinical correlation is valve involvement. Overall, just in the general population, the mitral valve is the most commonly affected site for infective endocarditis. But if a patient has a history of intravenous drug use, the epidemiology flips completely. In IV drug users, the right-sided tricuspid valve becomes the absolute most frequent site of infection, very often involving Staph aureus. A really great memory trick for this is don't try drugs. Intravenous drugs go directly into the veins, travel straight to the right side of the heart, and hit that tricuspid valve first.
You've now got the tools you need to completely master the clinical presentation of infective endocarditis. Just remember from Jane, and you'll be spotting these classic peripheral signs from a mile away, and you'll know exactly how they fit right into the Duke criteria. If its explainer gave you that little extra push for your studies, be sure to engage with the channel so you don't miss our next breakdown. So, what mnemonic should we decode next? Let me know. Keep studying hard, trust the process, and until next time, salam.